Today we're going to be discussing eating disorders and substance abuse. Let's begin with a discussion of eating disorders. First of all, gender is a risk factor for an eating disorder. Anorexia, bulimia, and binge eating disorders are typically characterized as female afflictions, but they also cross gender lines. Eating disorders among males often go undiagnosed. Age is also a risk factor for an eating disorder. Between the ages of 14 to 18 is the most frequently observed time period for emergence of anorexia and bulimia, although a later onset can occur. Binge eating usually develops around the age of 18. Race is also a risk factor for an eating disorder. Being Caucasian is often associated with anorexia and bulimia. Binge eating and obesity are a little more common with minority populations. Other risk factors for eating disorders include socioeconomic level and family characteristics. Anorexia and bulimia are usually associated with middle and upper socioeconomic levels of binge eating and obesity with lower socioeconomic levels. Bulimics tend to have families that are chaotic and conflicted, while anorexics tend to have families that are over-controlling and rigid. Other family characteristics are that binge eaters often feel neglected and overlooked and have a family member with a weight problem, or there's an affective disorder or alcoholism present in the family. There's also tends to be a risk factor for those who have identified with the social norm, valuing thinness. The symptoms of anorexia nervosa include a body weight of 15% or more below normal, an intense fear of gaining weight even though underweight, a distorted body image, and an absence of 3 consecutive menstrual cycles. They may be classified as either restricting or binge eating purging. Symptoms of anorexia nervosa in terms of psychological tend to behaviorally, you might see extreme physical activity, extreme food restriction, preoccupation with food and eating, compulsive exercise, and abuse of laxatives, diet pills, or diuretics. Physically, you may see a noticeable weight loss of 15% or more of total body weight, cognitive disturbances, hypersensitivity to cold, lanugo, which is the growth of fine facial and body hair, and malnutrition. The symptoms of bulimia nervosa are similar to those of anorexia, so let's cover those quickly. The binge eating episodes in bulimia tend to be in a short period of time accompanied by a feeling of lack of control. There also seems to be compensatory behavior such as self-induced vomiting, use of laxatives, diuretics, enemas, or other medications, fasting, or excessive exercise. Other symptoms include episodes occurring twice a week for at least 3 months, a self-evaluation unduly influenced by body shape and weight. The disturbance does not exclusively occur during episodes of anorexia nervosa, and here again it can be either purging or non-purging. Psychological symptoms of bulimia include low self-esteem, a high need for approval. Behaviorally, you may see cyclical binging and purging, restroom visits after meals, an abuse of laxatives, diet pills or diuretics or exercise, a preoccupation with food and body image, poor impulse control, or hoarding food. Physically, you may see normal weight, irritability and fatigue, but you may see tooth decay, gum disease, swollen neck glands, esophageal erosion, an occasional burst of blood vessel in the eye, and gastrointestinal problems. Other symptoms may be eating a larger than normal quantity of food within a discrete period of time, a sense of a lack of control, eating much more rapidly than usual, eating until uncomfortably full, and eating large amounts when not feeling hungry. Other symptoms include feeling disgusted with oneself, depressed, or very guilty after overeating. This occurs at least 2 or more times per week, and it's not associated with regular or inappropriate compensatory behaviors such as purging, fasting, or excessive exercise. We can do a lot to prevent eating disorders through education, an early detection of symptoms, self-esteem enhancement, and individual and family counseling. At the family level, we can provide parent education, showing an early detection of symptoms, family counseling for dysfunctional communication in families, behavioral sequences, investigating the power hierarchies and the boundaries within the family. At school, we can provide education for both teachers and counselors so symptoms can be detected early, and access to mental health counseling for adolescents and their families. Within the community, public service announcements and media coverage of eating disorders is necessary, as well as a change in societal norms. Now let's talk about substance abuse. So thinking about this, we need to think about and ask ourselves what drugs are currently being used and abused. What psychosocial factors influence adolescent substance use and abuse? What types of prevention and intervention strategies can be implemented for adolescents and their families? And what adaptations need to be made for cultural differences in the prevention and intervention of substance abuse? Substance use can be determined by the frequency of use, the quantity typically used, the variety of substances used at the same time, the social context in which drugs are used, and the emotional state of the user. The problem is that drugs are not inherently good or bad. The attributes of who is taking drugs and for what purposes, when and where they are taken, and how much and how frequently drugs are taken that influences value judgments regarding certain chemical substances. The soil that tends to nurture drug abuse includes poverty, racism, community and interpersonal violence, a lack of educational and job opportunities, and the dissolution of communities, including interpersonal and family problems. The two most important and direct predictors of teen drug use are peer drug use and low parental monitoring. That is, parents who are detached and disconnected from everyday activities of their child's life. There are also multiple peer influences. Peers are very strong influences on a youth's drug use and predict the age of initial drug use. Peers provide information about drugs, shape attitudes towards drugs, and create a social environment for drug use, give rationales for using drugs, and make drugs often available. Peer cluster theory emphasizes that drug use is linked to these peer relationships. Further, teen drug use is also a function of positive reinforcement by peers. Individuals actually get benefits beyond the physiological reinforcement. Peers offer social reinforcement by bestowing attention and status on the using teen. Family influences include low parental monitoring, poor parental-child relationships, deficient parental limit setting, weak problem-solving and communication skills, parental substance abuse, lenient attitudes about school, authoritative and punitive parenting. Some of the personal influences include drug dependency is associated often with the inability to cope with psychological pain. Drug use can become a relief-seeking behavior aimed at alleviating both internal problems such as depression or stress, as well as external problems such as academic problems and family conflict. Because relief through drugs is only temporary, drug use becomes part of a downward spiral. Other personality characteristics associated with pervasive substance abuse include pleasure and sensation-seeking behaviors, such as rebelliousness and a need for excitement, risk-taking, if you will, an acute desire for independence and autonomy, low interpersonal trust, and low impulse control with a poor ability to delay gratification. The physiological consequences vary with drug use. The long-term consequences of drugs, most severe, are alcohol, which include liver disease, cancer, cardiovascular disease, and neurological damage, marijuana, which is impairment in processing and storing newly learning material, and recurrent bronchitis, and narcotics, which include a severe impairment of the nervous system and internal organs, including essential brain functions. Some of the psychosocial consequences are high levels of teen use that are associated with early and risky sexual involvement, failure to pursue educational opportunities, and early entrance into the workforce, as well as unemployment or underemployment. Alcohol use in teens has specifically been linked to physical fights, academic failure, occupational problems, and finally juvenile criminal behavior. Here are just some few interesting psychosocial facts. Moderate use of alcohol has been found to increase the sense of being integrated with others, increase positive self-perceptions, decrease loneliness and self-derogation. Yet the use of more serious drugs increases loneliness, depression, and suicidal ideation and seems to decrease social support. Now let's move on and discuss the pathophysiology of drugs. There are 4 phases. Phase 1 is how the drug is absorbed into the body. It can be taken orally or swallowed. This is the most common method and enters the bloodstream by being absorbed through intestinal walls. Examples of drugs that are swallowed or taken orally are alcohol, tranquilizers, and stimulants. Drugs can also be smoked or inhaled. They enter the bloodstream by being absorbed through the lungs. Examples of drugs that are smoked or inhaled include marijuana, nicotine, and inhalants. Drugs can also be snorted. Here they enter the bloodstream by being absorbed by mucous membranes. Examples here would be cocaine or crank. They can also be injected, either through the vein, which is called mainlining, or under the skin, which is called skin popping. Here they're entering the bloodstream directly via the shot. An example of this type of drug would be heroin. After drugs have entered the body, they enter phase 2. The second phase is how the drug is transported. The drug is transported via the bloodstream to the part of the body where it will exert its effect. Phase 3 is the action of the drug. This is the effect or action of the drug. It depends on the type, potency, and purity, the contaminant or ingredient used to cut the drug, the personality and physiology of the user, and the social environment. Phase 4 is how the drug is excreted. This is when the body metabolizes the drug, its action is stopped, and the drug is excreted from the body. Drugs influence specific structures of the brain that are responsible for particular thoughts and behaviors. The major impact is on neurotransmitters, chemicals released by nerve cells throughout the central nervous system. Neurotransmitters influence the transmission of nerve impulses from one nerve cell to the other. Now let's talk about some specific drugs and their effects. First, let's begin with alcohol. As the blood alcohol level increases, we will see decreased alertness, relaxed inhibition, impaired judgment, increased heart rate, and a general sense of feeling good. Reaction time is slowed, and we can have both sensory and motor capabilities that are impaired. The withdrawal symptoms for alcohol include tremors, perspiration, agitation, disorientation, and brief seizures. With prolonged abuse, we get gastritis with hemorrhaging and inflammation of the pancreas that can result. Bleeding, severe vomiting, and changes in the blood necessitate hospitalization. This increases the risk for certain cancers including liver, throat, esophagus, the larynx, liver cirrhosis, immune system complications, brain damage, and harm to the fetus during pregnancy. To understand nicotine results in a kick because the sudden release of epinephrine stimulates the central nervous system to release glucose for low energy. After the glucose is used by the body, a period of low energy leads the user to more nicotine. Smokers generally have increased heart rates, decreased blood flow, and oxygen to the skin, resulting in smokers appearing older than non-smokers. They tend to have less flexibility in the artery walls, increasing the risk of severity of hardening of the arteries. They also have higher expectancy rates of lung cancer, emphysema, and bronchial disorders. Marijuana alters the metabolism of serotonin and dopamine. Heavy marijuana smoking has been linked to the amotivational syndrome of lethargy and decreased motivation in adolescence. The effects of smoking marijuana include lower secretions of sex hormones, impaired motor coordination, reaction time, and sensory perception, and decreased ability to follow moving objects. There is an increasing belief that marijuana smoke also affects the lungs in a manner similar to tobacco smoke. Inhalants contain hydrocarbons that cause short-lived, strong euphoric highs that last from a few minutes to several hours if repeatedly ingested. Symptoms of inhalant use include lack of coordination, restlessness, confusion, disorientation, difficulty walking, and delirium. One-time use of inhalants can cause death by acute intoxication. Sudden sniffing death can occur when exercise and stress immediately follow inhalant abuse. Chronic use of inhalants can result in hearing loss, limb spasms, brain damage, and bone marrow damage. Methamphetamines release high levels of neurotransmitter dopamine, which stimulates brain cells, often resulting in euphoria, wakefulness, increased libido, and inhibited pain. The side effects of methamphetamines include paranoia, repetitive behaviors, jaw clenching, tooth decay, also called meth mouth, hyperthermia, hypothermia, and an increased heart rate and blood pressure. Continuing, you may see irritability, aggressiveness, tremors, convulsions, anxiety, and increased metabolism. Chronic long-term use of methamphetamines can lead to psychotic behavior, anhedonia, kidney damage, liver damage, anorexia, insomnia, and stroke. Methamphetamine damages brain cells that contain the neurotransmitters dopamine and serotonin. The damage to the brain caused by methamphetamine use actually reflects the same sort of damage caused by Alzheimer's disease, stroke, and epilepsy. Prescription drugs, such as oxycodone or OxyContin and hydrocodone or Vicodin, are often abused for non-medical purposes. Common central nervous system depressants abused for non-medical purposes include Valium and Xanax. The possible side effects of these medications are seizures, decreased heart rate, and respiratory depression. Stimulants most typically abused by adolescents are Adderall, Concerta, and Ritalin. Stimulants increase alertness, heart rate, blood pressure, and energy, and stimulants may cause high body temperatures, irregular heart rates, and seizures. If misused, stimulants can be addictive. There's a continuum of drug use. First, let's consider risk and protective factors. Risk factors for drug use include biological vulnerabilities, self-drug use, parental drug use, and conflicted parent-child relationships. They also include mutually affectionate, non-conflicted parent-child relationships actually seems to prevent the development of risk factors. And finally, adaptive family functioning seems to be critical in offsetting multiple risk factors for adolescent drug abuse. In terms of our protective factors, we've already mentioned one, non-conflicted relationships. But other protective factors include a strong bond with family, an experience of parental monitoring with clear rules of contact within the family unit, and involvement of parents in the lives of their children, success in school performance, strong bonds with pro-social institutions such as the family, school, religious organizations, and an adoption of conventional norms about drug use. There are multiple intervention strategies. Two empirically validated individual interventions for adolescent substance abuse are behavioral management approaches and cognitive behavioral therapy. The basic goal of behavioral management approaches is to replace maladaptive substance use behaviors with healthy adaptive behaviors. Cognitive behavioral intervention approaches implement multiple components derived from classical conditioning, operant conditioning, and social learning perspectives. Specific intervention strategies include school intervention programs, family interventions, community interventions, student assistance programs, systems of change, and motivational interviewing. At the individual level, we find that to intervene, we need to utilize individual counseling for adolescent substance abuse. We can also use motivational interviewing to be specific. It's more successful youth that they have a problem and want to change. Those who are less likely to be successful are referred by the criminal justice system, use drugs for a longer period of time, are more immersed in the drug culture, some from families where the adults are substance abusers and have histories of violence and gang involvement. When working with children on their motivation, we need to consider stages of change. This is sometimes referred to as the trans-theoretical model of change, and this is a framework that bridges all theoretical approaches. The stages of change model suggests that individuals change when they are ready, and that this change is dynamic. There are 5 stages of change: pre-contemplation, contemplation, preparation, action, and maintenance. For students to be successful in overcoming drug abuse with motivational interviewing, we hope that they are in the action stage. Motivational interviewing increases motivation by minimizing resistance during discussions of difficult behavior change and developing awareness of ambivalence about current behavior, grounded in discrepancies between its and values or standards in our goals and hopes. It is a client-centered directive method for enhancing intrinsic motivation to change by exploring and resolving this ambivalence. This uses the stages of change model, and it helps resolve persons' ambivalence about change and motivates people to make a life change. The spirit of motivational interviewing is a way of being with a client. The spirit in which MI is delivered is as important as the techniques that are used. The spirit of MI is characterized by a warm, genuine, respectful, and egalitarian stance that is supportive of client self-determination and autonomy. Autonomy is honoring and supporting the client's personal responsibility for change. Collaboration, where we're meeting the client's and professionals' aspirations, and evocation, which is drawing out the client's concerns, wishes, hopes, strengths, goals, values, and intentions. The principles of MI include expressing empathy, where we're working to understand where the client is coming from, understand their story and their ambivalence, their introview, and find a way to let them know it. We're trying to develop a discrepancy between the current behavior and the behavior of their goal. So we're trying to help the client see that the current behavior does not fit in with his or her goals and values. An example statement that might help develop a discrepancy is this. On one hand, going to college is very important to you. On the other hand, you keep missing classes. Help me understand how these two things fit together. We also need to roll with resistance, and this is the idea of wrestling versus dancing. Don't get stuck in a tug of war. And finally, supporting self-efficacy. Remember that clients are the expert on the change that they need to accomplish. They have accomplished this change in the past. We just need to build on it. Motivational interviewing also relies on frames: feedback, responsibility, advice, menu, empathy, and self-efficacy. The effective elements of this brief intervention that encourage the client to focus on the positive. Intervention strategies at the family level include parents needing to communicate that they are opposed to any drug use and that they intend to enforce that position. Parents are encouraged to be understanding, firm, and self-examining. There needs to be a balance between adolescent autonomy and family, particularly as low family attachment and involvement are associated with an increased risk of substance abuse. And there might need to be behavioral contracting between parents and adolescents. Recall that inconsistent parents who do not monitor their children's activities contribute to a high risk for drug use. So again, family interventions need to target parent management, parent monitoring, and family norms for regarding substance abuse. At the school level, multi-component programs are more effective than unidimensional approaches. Regardless of whether the program is formal or informal, it should address these factors: the peer use and illicit substances and peer pressure, familial relations and cultural influences, and media influences. Finally, it needs to incorporate behavioral, cognitive, and affective strategies in all treatment efforts. School intervention programs are successful and ecological in nature. They need to begin in elementary school and include families, schools, and the full community. There should be two goals: to delay the age of first use and reduce the use of gateway substances. Two examples of these type of school intervention programs include the Good Behavior Game and Positive Action. Student assistance programs are school-based programs that include representatives from administrators, teachers, counselors, parents, and a substance abuse specialist. They have a structure for identifying substance abusing students. They provide a network to community resources that provide treatment, including a re-entry program with case management and follow-up for students returning to school after treatment. Intervention strategies at a community level include community-based programs such as drug-free programs, residential treatment facilities, daycare programs, aftercare programs, and therapeutic communities for adolescents with the most severe drug abuse problems. Currently, though, there is a severe shortage of community programs for teens. Again, some examples that we discussed previously are things like communities of care, residential programs, daycare programs, and aftercare programs. Here's a warning. It should not be assumed that an empirically supported treatment that has not been tested with a minority group is necessarily effective for that group. Adolescent substance abuse is a serious issue, and therefore researchers, parents, school systems, and counselors cannot afford to administer a one-size-fits-all prevention or intervention program. In conclusion, the most effective strategies for preventing substance abuse involve schools and families, and treatment is most effective when schools, families, and the community collaborate. It is critical to understand and attend to the influence and attitudes of the peer cluster, and youth should be helped to understand their responsibility for making change in their own lives.